Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically anytime by using the chat pod located to the right of your webinar platform. You may also download a copy of today's presentation using the Files pod located to the lower left-hand side of your screen. It is now my pleasure to turn today's conference over to Chris Hunt. Please go ahead.
Thanks, Brandon. Hi, everybody. This is Chris Hund, Director of the AHA Team Training Program here at the American Hospital Association Center for Health Innovation. Thank you all for joining us today on this April day. Lovely to see you all chatting in where you're all coming from around the country and around the world. So appreciate you all taking an hour to join us today. Today's topic is creating a culture of safety. We'll be with Dr. David Feldman in just a couple minutes. Just the rules of engagement here. It's very important to look at this and to see that you can access the audio for this in two different ways. So you could listen through your phone. If you're doing that, you're going to want to mute your computer speakers because otherwise you get all kinds of crazy feedback and it sounds funny. Or you could listen through your computer if you have a solid internet connection. We're going to do a Q&A session at the end of the presentation, so that will be your time to ask all kinds of questions. The way we like to do it is we like to have people chat questions into the box as we go, as you think of things, and then we'll put together a nice curated Q&A for the end of the presentation. If we don't get to all of your questions, feel free to email us at our email address, which is teamtraining@aha.org. We'll put it up on the screen in a second, and that will be a great way for us to get your questions answered. Just a couple upcoming events here at the AHA Team Training world. Our master training courses for TeamSTEPPS are open. A lot of the spring courses are filling up. We're starting to get wait lists at a couple of them. So if you want to come to a TeamSTEPPS master training course at one of our regional training centers, earn continuing education credit, and become a master trainer, the course schedule is here. You could link to it, and it will open up another browser page so you don't lose the webinar. We also have something new that we're trying out that we're developing right now. It's called TeamSTEPPS Next Steps. And TeamSTEPPS Next Steps is for people who have already started their TeamSTEPPS journey and they now want to kind of have more influence. So we're saying that you become a TeamSTEPPS influencer coming to this course. What we'll do is we'll really do a deeper dive into your implementation plan. We'll help you understand how to amplify the successes you're already having and how to deal with the challenges that you might have going on. So it's going to be a day-and-a-half course. It's going to be June 11th and 12th in San Antonio, Texas, right before our national conference. So take a look at it. It's going to be very focused on how to solve problems using design thinking. So what this is a lot of different creative ways to unlock the ways you're looking at what's going on in your situation. So take a look and check it out and shoot us a message if you have any questions. Our next monthly webinar is also coming up, May 8th, Building a Culture of Respect to Improve Patient Safety, Medical Team Performance, and Patient and Staff Satisfaction. So you can register for that right here as well. One more thing really to talk about is our national conference, the 2019 AHA Team Training Conference in San Antonio, the 12th through the 14th. We've got a variety of pre-conference workshops, the aforementioned TeamSTEPPS Next Steps, a master training course, and 3 different 4-hour sessions that you could choose from on the 12th. So if you're interested in attending the conference, you can learn more by clicking there and registering. It's a conference whose scope is growing. If in the past you've attended and you've thought, wow, it's all I learned about was different ways of doing things with TeamSTEPPS and it was really helpful, that's still a part of this. But now we're also getting into other areas, basically anywhere that teams help in the healthcare environment. So we'll be talking about high reliability, just culture, different things that teams can really connect into. So check it out. It's driven by the community. It's entirely put together by people like you who've submitted to present at the conference. And so I think it's a great opportunity to really learn from others and do a lot of interactive sessions and meet a lot of people. It's a lot of opportunities for networking. One of the cool things about it is that your speaker today, Dr. David Feldman, is going to be one of the speakers at the conference. So if you like what you hear today, come on down and you get to do a little bit more with him and hear a little bit more from him. If you need to contact us, our website's here on the screen right now. Our email, if you have any questions at all, we'll get back to you as soon as possible, and then also our phone number. All right, without further ado, I'd like to introduce Dr. David Feldman, Chief Medical Officer and Senior VP at the hospital's insurance company. Really had the great pleasure of working with David for many years now. We've probably known each other for 5, 6, 7 years, doing a lot of cool things in New York, and I'm really excited for you to get to hear from him today. So I'm going to toss it over to you now, David.
Thanks, Chris. Thanks for the introduction, and it's been a pleasure working with you as well for the last, I think you're right, 5 or 6 years. So good afternoon. Well, it's afternoon here, so I'll say afternoon to everybody. Topic for today is creating a culture of respect, and I have to say it's kind of a strange medium to have this kind of conversation. We're talking about a culture and actually a culture of safety. So talking about a culture of safety, any kind of culture conversation is difficult to do when I'm staring at a screen and talking into a telephone. So you'll have to forgive me if it doesn't seem warm and fuzzy. It's kind of that kind of topic. But you will have an opportunity, as Chris mentioned, we'll be talking similarly at the conference in June, so hope to see many of you there. So let's talk a little bit about what we're going to talk about. We're going to talk about what I think the 4 critical elements of a safety culture are. In 45 minutes, obviously, I really can't do any of these topics justice, so we'll try and touch on all of them. If you have a particular interest in one or a number of these things, I hope we don't disappoint. But the idea for today is to give everybody an overview of what I believe are the critical elements in creating a culture of safety. So let's start down that road. This is our agenda, and these are the 4 topics. Probably doesn't surprise anybody that we're going to start out with talking about respectfulness. I believe that's a background. In fact, I would go further and say that's a prerequisite before doing any of these other things. And then we'll talk about the 2 big buckets that I view as critical to a safety culture, that is getting reliable teams, which is about our people, and reliable processes, the systems that we work in, and then overlying all of this, the concept of just culture, really to make it all work as well as it can. So you may have a sense that I'm a surgeon. I'm actually a plastic surgeon by background. And that will influence a lot of what I talk about. That's the thing I know best. It's where I'm most comfortable. But unfortunately, it's also a place where a lot of things go wrong. This is just a list of the sentinel events from the Joint Commission. Of course, this is all self-reporting, so it's not a perfect database, but it does give you an idea that for a number of years, surgical areas have been at the forefront of sentinel events, of adverse events. So I think I'd be justified in saying that using examples from surgery are probably relevant, but I would tell you that a lot of the things we'll talk about this afternoon are applicable in any areas where we're delivering health care to patients, and that includes outpatient areas and other non-traditional areas as well. So I hope you'll find that as well. The other thing I sort of like about an OR timeout as an example is it seems to encompass the 3 aspects of performance improvement that certainly when I was working in a hospital I was faced with. And I used to get confused about the differences between quality and safety and performance improvement. They all sort of seem to be the same thing, and in many places they are. Depending on the environment you're working in a huge academic medical centers, there's different departments for each of these. You get to a small hospital or even a physician's office, outpatient setting, there may be one person that's responsible for all of this. But it all gets wrapped up in an OR timeout where you have the opportunity to influence quality. When you think about going over things like DVT prophylaxis and antibiotic therapy as a way to make sure that you're delivering quality care, safety, of course, to make sure you're doing the right operation on the right person, and then efficiency, because we know reviewing these kinds of things in what really is an excellent teamwork event, this timeout, we also know there's data to show that it actually makes your operating room more efficient. So all of these things, sort of nice for me to do that, but it's the OR. So again, let's talk a little bit about respect. This is a quote from Lucian Leap, who's written a lot about respect. He's written a lot about patient safety, of course, but he's also written a lot about respect, and he said this all 10 years ago about what we're missing in healthcare around teamwork and respect, not surprisingly. So we're going to do some audience polling today, and if we could open the polling here, I'd like to ask all of you if you've been treated disrespectfully at work in the last week. Have you been treated disrespectfully at work in the last week? We'll give you a couple minutes to answer that. I'm seeing people responding in the chat box. You want to use the voting panel on the bottom of the screen, not in the chat box. Okay, Brandon, why don't we show the results? So everybody can see that. Looks like a third of you say yes. Interesting. Let's ask another relevant question. How many of you have seen others being treated disrespectfully at work in the last week? What about other people? Have you witnessed others being treated disrespectfully at work in the last week? Give you a few seconds to answer that. All righty, Brandon, you can show the results of this poll. So this is the reverse. 2/3 of you have witnessed people being treated disrespectfully. So clearly, we have a problem. And I would argue this is a biased audience. You folks are probably already in the lead in trying to create cultures of safety in your institution. So the fact that you all are still seeing this means it's still an issue. And not surprising, polls I've done like this before, it ends up being pretty significant across the board. So we still have a problem with this despite it being out there for a long time. This is a recent study I came across from the NHS over in Great Britain, where they looked at rude, dismissive, and aggressive communication between physicians. That's what the RDA is. 606 clinicians of different stages of life. They had not only students and people in training, but also senior consultants and registrars. And you can see it happens fairly often. 9 out of the 600 happen daily. Up to 34% actually of the polled population. It happens a few times per year. What I found fascinating was we all tend to think of these kinds of behaviors to be typical in specialties like surgery and other procedural areas, but over at least in the NHS, fully a third of them were in radiology, which I thought was kind of interesting. But clearly the problem is universal, not just here, but overseas as well. And what exactly, by the way, are we talking about? This is a great series of articles. Again, Lucian Leap published these in Academic Medicine a number of years ago. It's a 2-part series. And they talk about what is it that we mean when we say disrespectful behavior. And I think all of us are familiar with some of these things on the top: disruptive behavior, humiliating, demeaning treatment of nurses, residents, and students. But then you have this passive-aggressive behavior, which includes things like refusing to do tasks or doing them in a way intended to annoy others, sort of passive-aggressive. Passive disrespect, the resistance to following safe practices like hand disinfection, timeouts, even when there's been rationale that's been sufficiently described. Dismissive treatment of patients. You have quotes like, "She won't return my calls," or "They ignore me on rounds." "They talk about me but not to me," or "It was clear he doesn't like people who ask questions." Those kinds of comments reflect sort of a dismissive treatment of patients. And then finally, and I think this is something we're seeing more and more of as healthcare becomes so much more stressful, this idea of systemic disrespect that most of us who have worked in healthcare for a long time sort of take as part of the way we do business. But why is it acceptable even for us to keep patients waiting? We even have waiting rooms. I mean, that alone sort of sends a message to patients that, by the way, welcome to the office, you're going to be sitting here for a while. All of these kinds of things really come under the term of disrespectful behavior. So something to keep in mind. This is some work from Alan Rosenstein's group. I think I saw him on the call today. If it's the same Alan Rosenstein, I'm honored. This is the data that looked at surveys of clinicians and asking the question, is there a link between this kind of behavior and clinical outcomes? Does it make a difference? And you can see overwhelmingly, both for a general population of clinicians and those working in ORs, 10 years old, but I somehow think this is probably still true today, that most of us in healthcare believe this kind of behavior really does have an impact on quality. And there's more and more data to show that. I have some of it here to tell you about also. If you're going to do something to fix this problem, how do you create a policy? How do you create a program that's going to address this the right way? And again, in Lucian Leaf's article, they talk about these kinds of things: fairness, consistency, a graded response, a restorative process, surveillance mechanisms. I've always said that these kinds of things do exist for the most part for nurses and other employees, but they traditionally at least have not for physicians. So some of this is really equaling the playing field for both physicians and others, having the same sorts of processes available when people act in disrespectful ways. I think the folks at Vanderbilt probably, to my mind, have done this best. They've been doing it for a long time under their Center for Patient and Professional Advocacy. They have a professional conduct policy. They do training for faculty in these kinds of things. They have a list of what are they call credo behaviors. They have a policy. They have feedback. And they developed initially this PAR system, this patient advocacy reporting system, which is a way for patients to report about these kinds of events. And they've been doing this for a long time. They also have these graduated interventions. Again, the idea being that repetitive disrespectful behavior is really what we want to worry about. So informal conversations, what they call a coffee cup conversation, if things happen once. And then you can see there's sort of a graduated increase in the response if the repetitive behaviors occur. And this is not too dissimilar from progressive discipline policies, again, that employees often have for all things, including this kind of behavior. Here's some really interesting data from Jerry Hickson's group at Vanderbilt, published a year or two ago, looking at patient complaints and outcomes, sort of looking at the data behind Rosenstein's work. Here they linked this PARS data, patient complaints, with NSQIP data, National Surgical Quality Improvement Program data. And what they did was they started at time zero, you can see on the left, and they went back for 2 years before that to see the number of observations of unsolicited patient complaints about particular surgeons, and then looked at those surgeons' outcomes using NSQIP data for the following, I believe it was 30 days. And you can see for surgeons who have the largest numbers of unsolicited patient observations in the 2 years before the patient's operation, there was a higher risk, a higher incidence of surgical and medical complications. That really speaks volumes for why this is so important. More recently, they've developed actually something called the CORS, or Coworker Observation Reporting System. Same idea, but now it's an opportunity for peers to make these kinds of reports. Again, they use their electronic event reporting system to this, and they have a taxonomy for coding reports that I'd like to show you. I think it's sort of fascinating, and this is really just from last year. You can see what is it that these complaints from coworkers are about. A lot of them, or the 26%, are about poor or unsafe care, but most, 60%, are about disrespectful behavior, disrespectful communication. There's a whole bunch of other things around responsibility, integrity, and you can see the list. You can take a look at the article if you'd like. It's really fascinating what they found coworkers were complaining about when they made reports about their peers. And I think it sort of makes sense to put all of this together, both the CORS and the PARS data, when actually developing a profile for helping clinicians to do better at communication. So I think that's important to keep in mind. At Maimonides, I was there for a number of years. We developed something similar. We have a code of mutual respect. The link is here. It's available online. You don't need any kind of password to get it. It's a PDF file. Take a look at it if you'd like. Same ideas we've talked about, clear expectations of what we mean by respectful behavior. There is progressive discipline, specifically for physicians and, frankly, anybody else working in the hospital, whether they be vendors, students. It doesn't really matter. It applies to everybody. And again, we developed a skills training program. We had mediating conversations, and we did this sort of interesting respect survey that I'd like to show you briefly. We did this is for the OR folks, and this has been published in the ORN Journal a number of years ago. We asked them 7 questions over a 4-year period of time. In 2005 was before we started, 06 and 07 was sort of during, and then in 08 was sort of after we finished. We asked people, did they have a clear understanding of what this code of mutual respect was? And you can see the numbers are pretty high at the beginning. This is a Likert scale, so that's the top 2 responses, agree and strongly agree. Will it positively enhance my workplace? Of course, everybody said, why wouldn't it? Now we get to some critical questions. Are physicians and staff held to the same standard? We got a little better, but we still have a ways to go there. 30% or so of folks really felt that physicians and staff were not held to the same standard. Our leaders handled disrespectful behavior effectively. We got a lot better at that during that period of time. My favorite question, I'm willing to speak up when I see someone acting disrespectfully. You can see we did a lot better. And to me, I think that's a sign that we're getting to that culture of safety. People are willing to say something when they see disrespectful behavior. The analogy would be, if they're willing to speak up for those reasons, you'd hope they'd be willing to speak up when they see safety issues occurring too. And then finally, my favorite 2 questions here. I'm treated with respect by others, 60 to 70%. I treat others with respect, 90%. So the message here is there's a problem, but it's not with me. Kind of interesting. Part of our initiative, we actually handed out mirrors, little makeup mirrors that had Maimonides logo on the front. When you opened it up, there was a mirror on one side. The other said, the problem may be with me. And we told people they couldn't go home and give that to their spouse. So that's another tool you can use. Okay, we spent a lot of time on respect. You can see that I think it's really a critical part of this whole process. Without it, it's really hard to do anything else, which is why we spent a fair amount of time talking about it. Let's talk about teams. I have to say, I'm talking to a group of TeamSTEPPS folks. This is a TeamSTEPPS webinar. So I'm making an assumption that most of you are pretty familiar with TeamSTEPPS. So I'm going to try and get to really some more advanced tools. But first, let's ask a question of all of you. See how you do on this. What do you think an effective team should have? Thanks, Brandon, for opening the polling. Should an effective team have the same people working together for each task? Team members with similar backgrounds and training? A chance to practice before the real thing, or simulation, I guess you call that? Members that hold a shared mental model. What do you think an effective team should have? I'll give you a couple of seconds to answer that one. Okay, Brandon, you can show the results. Not surprised, proved my theory that all of you are experts in teamwork. Yeah, obviously, shared mental model is one of those catchwords in the world of TeamSTEPPS, and my colleague, our Chief Nursing Officer here, Pat Kiszczak, and I use that term all the time. It's one of our favorite terms to use when we say we're not really on the same page. I think you all get that. So, obviously, a team is about a group that achieves its goals through independent individual contributions. And I like this idea of thinking about going from a team of experts to an expert team. And that, again, a bit of a surgical example. If you think about all the folks that work in a cardiac surgery operating room, they each are individual experts in their own fields. But really what makes them click is when they work together as a team, that integration, that seamless integration, delivering expert care to a patient in need of that kind of procedure. TeamSTEPPS, I think you all know about. Again, the emphasis, I'd like to say, is not just on patient safety, but also on performance. I think that's a great way of getting people engaged in this. These are the benefits. You've all seen these before. Jim Bajan's group showed improvements in surgical, both morbidity and mortality. Dose-dependent, the more team training you gave people, the better the outcomes were. Here's some data from Annals of Surgery showing improvements in delay rates as a result of medical team training. Again, that speaks to the efficiency, the performance side of teamwork training. And then this a group from Brigham and Women's up in Boston who looked at OB outcomes as measured by the Adverse Outcome Index and the Weighted Adverse Outcome Score. And you can see statistically significant improvements before and after using teamwork training. So again, none of this is probably new to any of you. So you'd think that we'd fix this after so many years of doing teamwork training, but we haven't. There's a really interesting series just recently in the New England Journal from Lisa Rosenbaum. There's 3 parts to it over 3 separate New England Journal editions, and you can see all the things we need to think about when it comes to teamwork. I encourage you to read it. It's really an interesting read, and it shows we still have a lot of work to do to get our healthcare people to work as teams. Let's talk a little bit about what I like to think of as best practices in the world of teamwork, checklists, those kinds of things, advanced TeamSTEPPS, if you will. We all are familiar with the Joint Commission Universal Protocol. I would say when it comes to this, certainly with surgical procedures, if you're going to have the pre-procedure verification process, you need to have a conversation between attending surgeon and attending anesthesiologist. Again, in my view, a best practice. Site marking, again, should be done by the surgeon who's doing the procedure, and that surgeon should be present for both the timeout and the one who's performing the procedure. And again, at the timeout itself, having attending surgeons and attending anesthesiologists along with your circulating nurse present really is a best practice. That does usually mean there may be some delays. We used to have to wait sometimes for an anesthesiologist if they're covering more than one room. But in the end, in that balance between safety and efficiency, I think safety wins every time, and it ends up not costing as much time as you think. So worth considering when you're doing timeouts. This is the WHO checklist. We're all familiar with that. I have circled the part that I think is critical to remember. This is not supposed to be comprehensive, and in fact, you really need to look at checklists and create the checklist that works for you. Best practices, if you read Atul Gawande's book about checklists, or anybody who writes about checklists, certainly from the airline industry, the checklist works best when you have people who are using it created for themselves. Then they've bought into it and they know it's going to work for them, and it's a dynamic tool. It's one that you should be reviewing every now and then and making changes in it as you see fit. Checklists are great, but what happens when you use checklists in a vacuum? There's a study a lot of you are probably familiar with from the New England Journal a number of years ago. They required in the province of Ontario in Canada that every hospital use the WHO checklist in their ORs. So they gave them to 122 odd hospitals. You can see the data here that show really no difference in either mortality or complications before and after the checklist. And their conclusion was the checklist, at least in this case, didn't really make a difference. Lucian Leap's editorial in that same journal really pointed out what the problem is. 90% of these folks that provided copies didn't make any modifications to either the WHO or the Canadian version of that checklist. They basically took the generic and used it. In addition, they didn't provide any team training or other support. It's very clear, I think, for people who really have figured this out, the checklist cannot be used in a vacuum. They need to be part of a comprehensive safety effort that, in this case, includes teamwork training, because that's what's going to make this really click. Using it alone is just not really going to work. Here's some other, I think, critical information that certainly helped me figure out how best to get teamwork to really work in your institution and be sustained. And this comes from Captain Steve Harden, who's done a lot of work through his company called LifeWings, helping train others in teamworks in healthcare. He's a former pilot. Actually, I think he still flies. And he talks about these 4 steps: providing information and demonstrating how to apply the information. And we do that pretty well. If you go to any typical TeamSTEPPS training or crew resource management training in your institutions, I think presenters who are expert at this can do a good job of giving people information, showing them how we apply it. When we've done TeamSTEPPS training, we've had often little skits and scenarios that show people how you do it, but that's really not enough. We can't expect folks, especially in healthcare and especially in surgical fields, where people are really used to doing things the way they're used to doing them, to just change all of a sudden based on something they hear in a conference. So we need to give these learners an opportunity to practice, and simulation, of course, is a great way to do that. Unfortunately, that's not so easy to do at scale. When you've got hundreds, if not thousands of people, you've got to give an opportunity to practice, and you need to give them feedback relative to a standard. When I was at Maimonides, we went around the ORs and filmed timeouts. I had a whole bunch of them, maybe 10 or 12 of them, and then showed all these videos to a group of OR, a big conference of OR folks, of surgeons, nurses, anesthesiologists, trainees, and so forth, a couple hundred people in the room, and we had them vote on which they thought was the best timeout. Now, all of a sudden, people have a sense of what we mean when we say, what does a good timeout look like? That's the kind of thing I think we really need to focus on if we expect people to take the tools we give them in these TeamSTEPPS program and use them on a consistent basis going forward. We did some of this with our hospitals. We developed a observation tool, really modeled off the MTPAT, that's the Medical Team Performance Assessment Tool, that the folks who wrote TeamSTEPPS came up with a number of years ago. We modified it. We got a group of 25 to 30 surgeons, nurses, and anesthesiologists together in a room and said, of the 25-odd TeamSTEPPS skills, let's look at the ones that are most important in a teamwork event. And we used the timeout and sign-out in the ORs, sort of a proxy for teamwork events, because if you think about it, if you're working in an OR, you're going to participate in a timeout or sign-out pretty much almost all the time. It's just part of working in an operating room. So it means everybody gets to do that. So we asked them, and they came up with about 9 or 10 of the 25 tools that they thought were the most important. We developed here a tool to be able to record these observations. Our Director of Research, Donna Somerville, because she's the one that's sort of behind all this stuff. The checkbox tool, it's kind of like a Survey Monkey, but the server sits here, so it's secure. And it's available to enter data on from any internet-connected device, phone, iPad, PC, and so forth. Then our hospitals train people to observe. Some put video cameras in. A couple did a little bit of each. And they gave feedback to surgical teams. Now, this is not so easy to do. It's hard enough to, at least it has traditionally been hard enough to convince folks, surgeons in particular, to do timeouts. Now you're going to tell them to do a timeout, and just before they're ready to start the surgery, ask them to hold on for a second while I give them some feedback on how they did on their timeout. That's a little tricky. One of our hospitals actually had the chief of surgery and the OR nurse director go around and watch these timeouts. They were able to do this. They have the gravitas. Also sends a nice message to your staff. When you have senior leadership watching people do timeouts, that it really does mean something. It's an important thing for them to do. So that's, I think, a critical part, this feedback. So one of our hospitals took a look at the differences between doing this kind of observation live versus on video. It was published last year. You can take a look at it if you'd like. And you can see that, interestingly enough, you might not have predicted that compliance, and I'll show you what the scores look like in a second, compliance was actually better, almost twice as good when it was done live versus on video. And there's all sorts of theories about that. People get used to the video camera being there. People say just put a video camera in the OR and don't have it connected to anything. That kind of thing to get people to think that somebody's watching them. We all know, because we've all been part of Joint Commission surveys where people are prepped, they know what to do, and then for some reason they just can't make it happen, or they forget somebody's there. So, we're humans. None of this is perfect. But I thought it was an interesting way of looking at the differences between doing this live versus doing this by video. I think just doing it at all and being able to give your team's feedback is important. Again, you're going to have to modify this for what works in your institution, but a couple of ideas for you. At another one of our hospitals, they took this tool and used it as a way to measure an intervention. So they looked at, these are the 6 of the 8 or 9 elements of this checklist that they created. Team assembly, you can see all of these things have direct correlations with a TeamSTEPPS skill. And there's somebody observing, did they comply, did they not, on each of these things. And you can see from July to December, and of course in between was the intervention, there was significant improvements in how the teams did on these elements of this tool and of the timeout. So it's a nice tool to be able to use if you want to measure the results of an initiative in trying to get people to do better timeout. So another sort of advanced technique for you. You can take a look at that as well. So that covers some of the rules, some of the tips we have for you on teamwork training. I suspect a lot of you are really expert at this as well. Those of you coming to the conference in June, I'd love to hear from you about your expert techniques in getting TeamSTEPPS to be sustained in your institutions. Let's talk about the other side of this, what we do to fix the system. How do we get the system that our folks work in to work in a way that keeps people from making mistakes? And there's a couple of thoughts, and I think some of this stuff is pretty cool, and we don't often think of ourselves in this way, using these kinds of tools. Here's an example. If you're coming home from a shopping trip with a couple of bags on your arms, which door would you like to encounter when you get to your apartment or your house? Obviously, the one on the right is a little easier if you can just use your elbows. I'm not sure how you'd have to get in. You'd probably have to have the neighbor come out and help you get into your place. It's just a sort of simple example of how these things really impact work efficiency. Here's some examples in healthcare. How do you label? I can't imagine how anybody could think the label on the left is at all appropriate for, of all things, epinephrine. I mean, there are rules about using this kind of color combination in PowerPoint. why do we think it's acceptable to use it on a label for a dangerous medication? So you got to think about these things. Make it easy for people to see what you want them to see, important information that needs to be available. Here's another example of too much of this labeling stuff. I can't imagine, a busy person trying to pick up a bag of an important medication, seeing all these labels. A human being can't process all this information quickly and efficiently, especially when under stress and when patients need something quickly. So keep that in mind when you start putting labels on things in a healthcare environment. Here's something simple about visual controls. Imagine these two stovetops. Is it easy to see in stove A which of the dials turns on which burner, as opposed to stove B where it's sort of intuitive? This is all just designing things in ways that seem sort of simple, and yet there are stovetops that look like they do on the left. If you walk into your OR, what does your anesthesia cart look like? Does it look like the one on the left, or does it look like the one on the right? And if you're a busy anesthesiologist reaching in a hurry for the propofol, wouldn't it be nice to know that every OR you work in, the setup looks like the one on the right, and the propofol is always in that one place? Doesn't mean you're not going to check the label anyway, but it just makes it so much less likely for you to make a mistake when you've got your system set up in a way that encourages you to do the right thing. It's really an important thing to remember. And then, of course, again, this whole idea of human factors engineering. In our hospitals now, over the last number of years, we've been using radio frequency to put chips in the sponges. Patients get wanded. It's kind of funny. A colleague of mine and I teach a course to medical students at one of our medical schools, and we ask them how we typically prevent ourselves from leaving sponges in patients, and they all say, well, we wand. Now, that's kind of an interesting response because a number of years ago it didn't exist, but for them, that's just the norm. Obviously, the answer is we count, and counting, even in the best scenarios, is just an imperfect process. That's why we know when patients unfortunately come back with retained sponges a couple of weeks after the surgery, the first thing that someone will do is look at the OR record, and invariably the count's correct. And the studies have said 80% of the time the count's correct, and of course it is. If it wasn't correct, we'd be doing x-rays and looking for sponges, and that's the problem. People are miscounting, obviously not on purpose, but if you have hundreds of sponges, a busy OR, and at the end of the operation, those of you who've been in ORs know it's not a quiet place where the circulating nurse and the scrub tech can count together. So we need to give them some kind of backup, or what the engineers call depth of defense, to make sure we don't leave something in somebody. And this, obviously, this equipment is not perfect, but it's another sort of pants over vest way of making sure we don't do the wrong thing. Barcoding is another way to back up our counting. Somehow, I think using a technology like this is probably a good thing to keep us from making mistakes, another part of this kind of topic. So, we've covered respectfulness as a background, as a prerequisite, if you will, for a safety culture. We've talked about the two critical parts that we can control: teams, how people work in teams, the processes, the systems, the environments we work in. How can we make those really make it easy for people to do the right thing, to prevent ourselves from making mistakes? Let's talk a little bit about just culture. Yes, that is me in a hang glider. I guess some would call that reckless behavior, maybe risky behavior, but I'm here, so I guess it's okay. All right, let's go on. A just culture, I think some of you, most of you have probably heard the term used before. It's really this balance. It's this balance between a culture where we punish everybody and one where nobody takes the blame, or nobody basically is held responsible or accountable for anything. So finding that sweet spot is really what this is all about in safety culture. And I think it's important to keep that in mind when you're developing a just culture. It's just not enough to say it's all a systems issue and we're not going to hold people accountable. It's just making sure we hold the people accountable for the right things. And that's really what I think this is about. All of you have probably read or seen James Reason's work, of course, and now David Marks here in the U.S. talk about this. There's lots of materials out there to help you. This is not an easy thing to do. It looks easy, but I promise you it is not. These are the three ways in a just culture we sort of think about people's behaviors. We talk about human error, where somebody does something that any other human being in the same scenario with the same background and training, they could have made the same decision, had the same behavior. We talk about at-risk behavior. That means we're looking at folks doing things that probably are riskier than they think are, or doing things that have risk when they think that it doesn't. And again, the way to deal with that is really about coaching folks, education, letting people know that what they did was probably riskier than they thought, as opposed to human error where we really need to fix the system. I've always said the typical example, sort of showing my age here, a human error when in the old days when lab techs used to have to write the lab results down and then just put them on a piece of paper and send them over to the ER or the floor where they came from. How often do you think a lab tech writing down CBCs all day is going to switch the white count and the red count? It's just a matter of time before that happens. So obviously the processes that we do have created much better systems for doing this. It's all really done automatically. But punishing somebody for doing that really doesn't make any sense when 9 or 10 people with the same background and training put in that situation could have made the same mistake. Again, risky behavior, often you need peers to be able to help understand whether somebody's actions were really riskier than they thought they were. And finally, and this is fortunately the rarity in healthcare, the idea of reckless behavior, behavior that is really considered going to harm a patient, or somebody knowingly does something that they know could harm a patient, really falls under reckless, and that clearly is the kind of behavior that we ought to punish. But fortunately, it's really a rare thing. I think if you look, in my opinion, over the last number of years, as people have started to adopt these kinds of constructs, I think we tend to go a little more to the human error thing than we probably should, and there's probably more risky behavior than we think there is. But again, this is tricky business. So let's look at an example, and we'll see what you all think, see how good you are at just culture analysis. So here's the scenario. Again, sorry about the surgical example, but that's what I know. So here it is. A surgery resident accidentally contaminates an instrument in the OR, and no one notices. Now, the instrument is critical to the procedure, and the resident knows that if the instrument has to be re-sterilized, it's going to delay the procedure by at least 20 minutes, either to re-sterilize it or to call for a replacement. And this is the kicker here. Knowing that the attending surgeon has a history of being abusive to residents, the resident says nothing. So let's hope you've all had a chance to read through that, right? Instrument falls on the floor. Only the resident sees it. He knows or she knows that if they do something, if he says so, he or she says something about it, it's going to delay the procedure by 20 minutes. The attending, at least in the mind of this resident, has a reputation of being abusive, and so the resident says nothing. So here's my question to you. Do you think that this resident's behavior, we're talking about the resident now, do you think the resident's behavior was human error? Would you console him or her? Was it risky behavior? Would you coach him or her? Or was it reckless behavior, and would you punish him or her? Let's give you a couple minutes to answer that. Okay, Brandon, you can show the results. So interesting, about 2/3 of you thought it was risky behavior, 1/3 thought it was reckless, and a couple percent of you thought it was human error. So I'm going to tell you there's no answer to this. Why? I don't know what the right answer is for this, to be honest, although you might be able to use something like this. This is the Just Culture Decision Tree from David Marks's Just Culture community. If you sort of take yourself through these steps, and we really don't have enough time to discuss this here, but this is kind of the thing that you want to use. You really have to do this methodically. You have an instinct. All of you voted on instinct, and I think many of you probably got to an answer you get to anyway, but it's good to have this to take you through the questions you want to ask. Was the job understood? Probably. The job of letting somebody know, if you will, that something's unsterile potentially. Were the actions as intended? Were the results as intended? And that's the tricky part. We don't know what the results are. It's hard to know whether the patient suffered an infection or not. In some ways, it doesn't really matter, does it? We don't look at outcomes when we're trying to establish a just culture. But in my sense, if you look at where you end up, if you go to no on one of those questions on the left, you end up with these questions that I think become critical. Knowingly violating procedures. Were procedures clear and workable? You could argue the resident having to speak up knowing that he or she was going to be yelled at by an attending, that you might argue is not workable. Again, this is I'm not an expert on this, but these are the kinds of questions you have to ask, and you can see why this is not so clear-cut. So you end up more to the right of this algorithm where you get into first warnings or even risky behavior and training. I guess the first thing I would do is find out whether the surgeon or in question really does have that reputation, or is it just this resident's opinion? There's lots of things we haven't answered here, but I think it gives you a sense, and the reason I showed this to you was it gives you a sense of the complexity of this. It really is not that simple. The other thing I would say under the guise of best practices again, one of our hospitals actually has a peer review committee for residents, and they use this model for that. So if you're going to judge people based on their behaviors, you want people who understand the positions you're in. So if you're going to evaluate a resident's behavior as an example, you might want to have residents be the one to determine whether that behavior was human error, reckless, or risky. And I think that's true whether it's a resident, a nurse, a physician. It's hard to understand what other members of the healthcare community face unless you have the same people kind of evaluation. I think that's a best practice personally. Unfortunately, we're not done with this. Some of you, probably many of you, have heard of this unfortunate incident at Vanderbilt where a nurse mistakenly gave a patient the wrong medication, and the state of Tennessee is actually prosecuting the nurse for reckless homicide. David Marks wrote a whole analysis of it. I encourage you to read it. It's fascinating. He has got a great take on this. And he concludes his analysis by saying, in this case, tragedy followed by injustice once again. I think all of us can agree that unless this was truly reckless behavior, prosecuting a nurse for something like this is really not going to help anybody. So something to think about going forward. So we're actually at the end. We've talked about respect as a prerequisite for a safety culture. We've talked about creating reliable teams and reliable processes. Talked a little bit about how you apply a just culture to this whole system to give people the opportunity to speak up, knowing they're not going to be punished for things that are human error or even risky. And I hope you found it helpful. I think it's time for me to turn it over to Chris for Q&A. Chris?
Thanks, David. That was really great. Thank you. It was almost like a roadmap for where we all need to get going. You know, you said something earlier on when you were talking about checklists, about how everybody, can kind of agree that checklists cannot be used in a vacuum. And it seems like it's more than that. It's almost everything you've talked about probably can't be used in a vacuum. You can't do just culture without addressing, human factors when, certain processes are broken or whatnot. You can't have, people really addressing certain problems without there being a strong team in place. So really, really good. Thank you very much. Right.
You know what, Chris?
Yeah.
Chris, before we go on, just a couple of comments under the Q&A topic. I was thankful to your team for getting me a list of pre-questions, which sort of got me thinking. Just a couple of quick comments in summary that I hope will be helpful. There's a lot of questions, at least before the webinar, about how you engage physicians in particular, and my suggestion is, most physicians, the way they think about this stuff, fall into a normal distribution like many things in life. You want to find the docs that get it and try and get them to help you. For the rest of the great masses, it's a marketing principle of what we call WIFM, W-I-F-M, what's in it for me, unfortunately. In the OR, it's pretty easy. You can try and make the case that doing these kinds of things is going to make their life easier and more efficient and hopefully better for their patients. And that's a good way to appeal to them. I really believe in rewarding people who speak up. Handwritten letters are unusual these days, but it goes a long way and it costs nothing but literally a few seconds of your time. Public acknowledgement. We actually publicly acknowledged a nurse who actually spoke up when a surgeon was using a non-radio opaque lap pad in a aneurysm case. And we publicly called her out for being willing to do that, which you can imagine was not easy. And we did it at an OR meeting and those kinds of things. We talked about respect and the range of disrespectful behavior. Keep that in mind. A lot of folks asked about how you do this in big systems, small systems. I think you need local champions. And local can be really local. Even within a hospital, having this, I'm a big believer in physician-nurse dyad, nurse-physician dyads. I work in one myself, as I mentioned. I have a chief nursing officer, and we work very closely together. And we've observed in our hospitals, the places they do this best, there are those kinds of systems, dyads of physicians and nurses working together to get this stuff done. You need a top-down, bottom-up approach. You have to have your leadership, your high-up leadership to do this, especially the respectful behavior piece, but you need people at the front lines who are delivering care to buy into this as well, or it will never work. If you're in a small practice, remember that efficiency is a big way to sell this to folks, and you want to create a place where people want to work. Let's be honest, folks. In healthcare, it's stressful enough. People want to get up in the morning and go to work and feel like they're being rewarded for what they do, even if it's just a pat on the back. They want to feel like it's a nice place, they're doing something positive for patients, and they like the people they work with. Measuring culture, people ask a lot about how you measure this. I have to tell you, it is very difficult. It's sort of a feel. It's kind of like when you walk into a Ritz-Carlton hotel or one of these high-end hotels, it has a feel to it. They've managed to do that. They've developed that culture. You want that same feel. You want people walking into your hospital going, people in this hospital are really nice. They treat me respectfully. And how do you measure that? I'd love to hear your thoughts on it because it's not easy. You can do surveys, but that's not so great either in some cases. People talk about developing trust. I think trust comes from respect. Someone asked about doing, can you do just one or two skills? Of course. Pick the skills that you want to work on first. You can't do all of this. Focus on a few things and get some big wins with those. And then finally, sometimes, unfortunately, you need a burning platform, and that could be a bad event. It could be a Joint Commission survey. It could be some public relations debacle. Whatever it is, sometimes it's horrible to say, but sometimes those things actually help you really push the gauge, if you will, and get people really on fire, if you will, to do this. So I hope that helps answer some of the questions preemptively, Chris. Sorry.
Yeah, no, I think it does. I mean, we had actually just had a question come in over the chat box about, how do you get people on board with something like TeamSTEPPS or any of the other things you're talking about, really. And I think that, really it's that what's in it for me is a big part of things, right? And allowing people also to have that ownership to devise the system themselves. You talked about that with the checklist, and I would say that's the same with any of these TeamSTEPPS, any of the programs of saying, we're going to do this, but it's up to you to come up with, how we're going to do this. All right.
Agreed.
Yeah. So a couple other questions that have come in. One of them was a little bit earlier on. And this kind of goes, I think, to some of your other work that you do with the insurance company. It says, what are some of the best practices in improving either hospital or clinic safety culture from interventions coming from carriers or risk management organizations? What are some of the things you're seeing there?
Do we have a few hours? That's what we do. As you know, I'm the chief medical officer for a captive insurance company. So we're really an extension of our hospital's risk management department. And this is not a webinar about malpractice data, but I could probably talk forever about it. I think there's a lot of value to using malpractice data. Talk to your carrier. Find out how you can get a hold of this. And it's compelling. Two reasons why it's compelling. One is it's very detailed. And as well as we do, as good as we do in root cause analyses, and there's a long way to go on that, in finding out what really happened, it's never as detailed as what you read when you read about a lawsuit. And part of that is just the nature of things. When people are questioned in regard to a lawsuit, they sort of bare their souls. And you get information like what people were thinking about. What was their day like that day? How busy was the place that these things happened in? It's very rich information, so it does add a lot of quality to what you're trying to get at. The numbers are small, admittedly. The number of claims are small, but the second big piece of information, the dollars are huge. Certainly, I work in New York City. The dollars are really huge, and it can make a very compelling argument to get people to invest in your program if you can show that there's a number of malpractice cases with a specific theme that cost X number of dollars to your hospital. How hard is it to explain to even a finance person to spend 10% of that? The ROI is easy to show. So that's a general tool that I would suggest using. It's the place I work in, and it does go a long way in trying to push some of these things and getting the resources to do it.
That is the way to, one of the ways to really speak to leadership too. A lot of people are coming at this from that grassroots way, and they need that kind of advice, I feel, to be able to speak to leadership. So good. Couple real more specific questions. Recently, somebody just asked if you could talk a little bit about when you were talking about the videotaping of the timeouts in the OR, and how did you get around compliance issues with this, or how did you deal with that? Because these were real scenarios; these were not simulations, from what I understand.
Correct. Actually, so one of our hospitals has actually installed video cameras in their OR, and we're in New York City. So there's all the things you'd expect to have in New York City. There's often a unionized workforce. There are regulations, but leadership, surgical leadership in particular, was really emphatic about wanting to do this, and they dotted all the I's and crossed all the T's. It's not easy to do, but you can do it. Certainly happy to put you in touch with some of those folks if you think that would be helpful, but it does depend on the venue you're in. And I will tell you that the folks that have done this have told us it changed their culture. Just having the ORs in there. People know that there are cameras on all the time, and it's not watching the patient per se, it's watching what's going on in the room. And it's, look, there are cameras everywhere in the world. Why don't we have them in hospitals too? And we will. It's just a matter of time. We should get ahead of that and do it ourselves in a way that we can really learn from it. I'm happy to speak more about some of the real more detailed things you can do in ORs, not just with video cameras, but that's not a topic for today. And the other question about me walking around the OR with a video camera, I mean, that was something I obviously had to talk to my legal office about, but those were internal use. No patients were seen in those. It was just the staff, and the staff all, before I did it, I got their permission to take a videotape of them. And that was for a learning purpose. So you can do this, but you have to talk to the right people before you do, obviously.
Of course. All right. Do you have any thoughts on working with staff who are kind of working more independently? I'm seeing here the person is bringing up home care staff, but there's a lot of others that, work independently more. If you think about even smaller medical offices or anywhere that they're off, how do you instill some of these tools working with those folks?
That's tricky. Most of the folks probably on this call are in risk management or work in hospital quality departments. As soon as you get outside the hospital, there's very little of that. It's a deficiency in healthcare when you think about the fact that most healthcare is delivered outside of hospitals, right? Whether in home care facilities, that kind of thing. I've talked to some folks who are office managers, and they are it. They are the quality folks, the risk folks, the performance improvement, all wrapped up into the office manager, right? So how do we engage these folks? I think there's a lot to be learned, and there's a topic, Chris, for one of your upcoming webinars and conferences. I mean, it is a big deal, and we think about the last, not the last, but one of the big areas of safety that we've really not done very well in addressing in diagnostic errors. Most of those happen outside the hospital. Well, who's there to really help us investigate them and do all the things we do for inpatient errors? So, I don't have any magic answers for that. We're trying to figure the same thing out because in big hospital systems that have these kinds of outpatient facilities, the risk manager in the hospital, they don't have the time to start going out into clinics and offices, that kind of thing. It's a difficult problem. I don't have any magic answers for you, but it's a problem for sure.
Thanks. Yeah. I just saw the post there about the TeamSTEPPS for office-based care material. That was something that we worked on here at the AHA on a lot, but it is something that I still think there needs to be more work done in that field. So, you heard it here. Yeah. Dr. Feldman threw down the gauntlet for the conference next year in 2020. So if anybody has some great ideas, appreciate you getting in touch with us, and we'd love to work with you. Well, on that note, before I close everything, I just want to, thank you, David, for being here and presenting. Thanks to everybody that
My pleasure.
Was here and listened in and asked questions. We will be following up with David on any of the questions we didn't get to. So we'll try to get some answers on those. We also have a evaluation that will be coming out shortly, so we'd love it if you fill that out. That's always very helpful. And stay in touch with us. We have a lot of different resources that we can offer everybody. So, if you're interested in us coming out to you, we do on-site engagements. We've got the national conference, of course, and some of our other courses like the master training course and our TeamSTEPPS Next Steps course. So with that, I'd like to bid everybody a nice rest of their day. Thank you.
Thank you, ladies and gentlemen. This concludes today's event. You may now disconnect your lines.